All right. Hello, everybody. My name is Iris Perez, and I'm speaking to you from Los Angeles. I am the Associate Program Director of the USC Sleep Medicine Program, and I am based at Children's Hospital, Los Angeles. I am a new member of the Sleep Medicine Fellowship Directors Council and the Choose Sleep Subcommittee. I practice pediatric pulmonology and sleep medicine here at Children's Los Angeles. I do not have conflict of interest to declare. And before we start, we have a few housekeeping. Questions can be answered in the chat feature at any time during the presentation. And the questions will be answered at the end of the presentation. And to let you know that this webinar is being recorded and will be posted on the AASM website 2 to 3 weeks after the presentation date. So this morning, I am hoping to discuss the pathophysiology of obstructive sleep apnea in infants and children, review the risk factors for OSA that will help us identify patients, understand the nuances of pediatric sleep study interpretations, and review the available OSA treatments in infants and children and their outcomes. Pediatric obstructive sleep apnea is characterized by intermittent and prolonged complete or partial obstructions during sleep that result in gas exchange abnormalities, hypoxemia, as seen here in this slide, and or hypercapnia, as seen here with a CO2 retention of 50 and associated with sleep disruption. As you can see here, the obstructive apneas can be short or prolonged, but when they come in series, they're associated with significant oxygen desaturations. So how do we diagnose obstructive sleep apnea syndrome in children? The AASM diagnostic criteria indicates that there should be at least the presence of one symptom like snoring, labored, paradoxical, or obstructed breathing during sleep, sleepiness, hyperactivity, behavioral problems, or learning problems, plus a PSG manifestation of one or both, and obstructive apneas, mixed apnea, hypopneas of greater than 1 per hour of sleep, or a pattern of obstructive hypoventilation, which is described as 25% of sleep time with PCO2 greater than 50 or its surrogate with at least one or more of snoring, flattening of inspiratory nasal pressure transducer, and paradoxical thoracoabdominal motion. Childhood OSA is common. The prevalence is estimated at 1 to 4%, although the prevalence may actually be higher due to the rise in obesity in pediatric population. The peak prevalence occurs between 2 and 8 years of age, and this coincides with the development of adenotonsillar hypertrophy in this age group. And in prepubertal children, there is equal prevalence in boys and girls, but in adolescents, it may be higher in males. Risk factors for OSA include race. Several studies now show that African American children are 4 to 6 times more likely to have OSA compared to children of Caucasian origin. In addition, African American children with OSA have more severe OSA with increase in AHI, as well as higher risk of post-operative complications. Another risk factor is history of prematurity, where children who are born premature have a 3 to 5-fold increased risk of developing OSA. And this may be due to the presence of facial asymmetry, elongated head shape, exposure to prolonged intubation and nasal tube feeding that changes the architecture of the palate, and the presence of hypotonia. There is also increased risk of OSA in first-degree relatives. So what are the conditions associated with childhood OSA? We know about the risk of OSA in patients with adenotonsillar hypertrophy, those with obesity, and the other risk factors or conditions associated with pediatric OSA include nasal septum deviation, nasal turbinate hypertrophy, or presence of allergic rhinitis, presence of craniofacial abnormalities like retrognathia or retrusive chin, malocclusion, mid-face hypoplasia, such as seen in patients with craniosynostosis, and mandibular hypoplasia, such as seen in patients with Urban sequence. Patients with neuromuscular disorders or neuromuscular weakness like cerebral palsy, Duchenne muscular dystrophy, myotonic dystrophy, or spinal muscular dystrophy are also at risk for OSA. It is worth knowing that patients with neuromuscular disease may not have the diurnal or nocturnal symptoms that we generally observe in patients with sleep-related breathing disorder. However, there are some predictors that may help us think of these patients as having sleep-related breathing disorders. The pulmonary function testing can help predict the presence of OSA in patients with neuromuscular disease, whereby an inspiratory vital capacity of less than 60% can predict OSA or sleep-related breathing disorder, while an inspiratory vital capacity less than 40% and an arterial carbon dioxide tension of greater than 40 may predict OSA with nocturnal hypercapnic hypoventilation. Patients with mucopolysaccharidosis, a group of disorder associated with rare lysosomal storage, are at risk for OSA due to their narrowed upper airway lumen. Patients with Chiari malformation have brainstem crowding at the foramen magnum, and there is a caudal displacement of the cerebellar structures, the cerebellar tonsil or vermis, that results in compression of the cranial nerves that innervate the oropharynx, predisposing them to obstructive and central apneas, as well as hypoventilation. Patients with achondroplasia are at risk for OSA due to their mid-face hypoplasia, presence of hypotonia, as well as brainstem compression from craniocervical stenosis. We are going to discuss the risk factors and treatments of patients with Prader-Willi Syndrome and Down syndrome at the later part of this talk. So the gold standard in the diagnosis of OSA is polysomnography. The American Academy of Pediatrics task force recommends that polysomnography should be performed in children with snoring and signs and symptoms of OSA. So what does polysomnography entail? As you can see, these children are wired. We get the EEG similar to what we do in adults. We place nasal pressure transducer, oronasal airflow, and there's also a prong for end-tidal carbon dioxide monitoring. We monitor their arterial oxygen saturation with pulse waveform, the chest and abdominal wall motion to see for this how synchronous the respiratory effort are or how paradoxic the respiratory motion is, the body position, as well as a video. So there are differences between the scoring and interpretation of obstructive sleep apnea in children compared to adults. So we do know that for obstructive event duration is 2 breaths in children, and the scoring of hypopneas is 30% decrease in flow associated with 3% desaturation or arousal. In children, a normal AHI is less than 1.5 per hour. The hypoventilation is defined as the presence of carbon dioxide tension or its surrogate of more than 50 millimeters mercury for 25% of sleep time. In adults, the obstructive event duration is 10 seconds, as you all know. And depending on the rule that's used, 1A would be 3% hypopnea would be defined as 30% decrease in flow with 3% desaturation or arousal, which would be similar to that in children. Or with 1B rule, it would be hypopnea would be associated with a 4% oxygen desaturation. Compared to children, the normal AHI in adult is less than 5 per hour. And hypoventilation is defined as CO2 or its surrogate of more than 55 millimeters mercury for 10 minutes or more, or a rise of 10 millimeters mercury or more in CO2 during sleep compared to an awake supine value to more than 50 millimeters mercury. So comparing the severity of OSA in children and adults, mild is 1.5 to 5, moderate is 5 to 10, severe is greater than 10. There are some labs that use 2 as their abnormal, but remember the AASM says greater than 1 is considered abnormal. In adults, the severity of the OSA is classified as mild is 5 to 15, moderate is 15 to 30, and severe is greater than 30. So just thinking of when you get a sleep report, and it is important to look at how, 1, the events are scored, and 2, that will help you determine the severity of the OSA. Like for the AASM suggests that labs can use the adult scoring for children or adolescents who are 13 years and above. And so it's important to know what type of scoring is used when interpreting these sleep study reports. So this is an example of an obstructive hypopnea in a child showing at least 2 missed breaths, the presence of paradoxical breathing, and associated oxygen desaturation from a baseline of 96 to a nadir of 91%. So how are we going to approach OSA in children? Adenotonsillectomy is the first line of treatment. And because large tonsils and adenoids are is the most common in general cause of OSA in healthy children. Therefore, it's important to have our otolaryngology colleagues involved, where they can perform a sleep endoscopy to identify sites of obstruction, as this will determine the outcome of the procedure or if other procedures or treatments are needed. While waiting for your patient to be seen in the otolaryngology clinic or to be evaluated by your ENT colleague, you can perform a lateral neck X-ray to assess for adenotonsillar hypertrophy. Sometimes it's a little bit hard to have these children open their mouth. And you can do a chest X-ray to assess for heart size and assess their lung fields, particularly in those who have sleep studies with significant hypoxemia. In those with sleep-related hypoventilation, a blood gas can be performed to assess their daytime ventilation. And patients with severe OSA should be referred for echocardiography to assess for pulmonary hypertension and right ventricular function. So is polysomnography needed prior to adenotonsillectomy? We say yes, because studies have shown that the symptoms, the physical examination, and laboratory tests do not predict PSG findings in children. The clinical parameters like tonsil size or the loudness of the snoring does not differentiate OSA from primary snoring. And more recently, findings showed that the tonsil size, the Mallampati scoring, or the Friedman palate positioning does not predict the presence or the severity of the OSA. PSG findings can guide your therapeutic approach. If you're referring a patient for adenotonsillectomy, an adenotonsillectomy is planned, is this going to be done in the inpatient or can it be done in the ambulatory setting? The results of the polysomnography can help identify patients who are at risk for postoperative complications, as well as those who are at risk for residual OSA. The updated guidelines from the Otolaryngology Academy suggest that clinicians should admit children with OSA with documented polysomnography for inpatient overnight monitoring after tonsillectomy in those who are less than 3 years of age, those with severe OSA, and they define this as AHI of 10 and oxygen saturation nadir less than 80%. The American Academy of Pediatrics has a broader criteria for admission in addition to age less than 3 years of age and the severity of the OSA. Children with cardiac complications of OSA, such as pulmonary hypertension, those with failure to thrive, those with obesity, craniofacial anomalies, neuromuscular disorders, or intercurrent respiratory infections need to be admitted for inpatient monitoring. Because what happens, for example, if you have a patient with severe OSA, as seen in this portion of the slide, the patient will be at higher risk for respiratory complications and need for intervention postoperatively. So what do we know about the outcomes of adenotonsillectomy? In a study, we know that adenotonsillectomy results in significant reduction in the ASI, improvement in symptoms. But in one study, only 27% or 1/3 had complete resolution of OSA when defined as AHI less than 1 per hour. The risk factors in this study for persistent OSA include older children, those who are 7 years, those with obesity, those with high preoperative AHI, again, supporting the need for pre-TNA adenotonsillectomy, and those non-obese children with asthma as a concurrent or comorbid diagnosis. Other causes of persistent OSA and need for repeat PSG post-TNA include those children with persistent symptoms after treatment, those with moderate to severe OSA in the preoperative PSG have sequelae of OSAS, those with craniofacial deformities, those with neuromuscular disorders, and those with other more complex disorders. So other than adenotonsillectomy, what are the other treatment options? Intranasal corticosteroids and/or leukotriene antagonists have been found to be effective for mild to moderate OSA because the upper airway tissues have high cysteine leukotrienes in children with sleep-related breathing disorders. However, intranasal corticosteroids and leukotriene antagonists have been found to have a less favorable favorable response in those who are obese or those who are more than 6 years of age, and more recently also in patients with Down syndrome. So repeat PSG after 12 weeks is recommended by the European Respiratory Society in patients who are treated with intranasal steroids and or montelukast. How about watchful waiting? So some children may do well with observation. In a study in the child adenotonsillectomy trial, or CHAT, the investigators looked at 194 children aged 5 to 9 years who had an AHI of more than 2, obstructive apnea index of greater than 1, but who were not obese. They did not have severe OSA defined as AHI of greater than 30, or obstructive apnea index greater than 20, or had oxygen desaturations with SpO2 less than 90% and greater than 2% of the total sleep time. Those with recurrent tonsillitis, those who were obese, and those who were on medications for ADHD were included in this trial. And they followed these children for 7 months and observed them for their symptoms, with examination, and with their PSG. And they defined resolution as AHI less than 2, OI less than 1, and OSA symptom score with improvement from baseline. And what did they find? That close to 50% of children who were considered surgical candidates had PSG resolution. And the baseline predictors of resolution included lower AHI, smaller waist circumference, higher positioned soft palate, smaller neck circumference, and non-black race. Therefore, watchful waiting may be a reasonable option for children with low OSAS symptom burden, little snoring, low AHI, and without central obesity. But when looking at this same cohort, they looked at comparing early adenotonsillectomy versus watchful waiting. We need to know that early tonsillectomy in this group also resulted, however, in significantly greater improvements in behavior, quality of life, symptoms, and PSG findings. And in this group, there was a greater weight gain, even in children who were already overweight at baseline, and those who had failure to thrive normalized their weight after adenotonsillectomy. Another treatment option is the initiation of passive airway pressure, either with CPAP or BiPAP. And this is recommended if adenotonsillectomy is not performed or for persistent OSAS after adenotonsillectomy or other airway surgery. It is important to know that there should be a buy-in in pediatric population by the family. It's important to train them to acclimatize the child to the passive airway pressure, use appropriate interface, either nasal or mouth or face mask. And similar to some adults, adherence is a major barrier. Therefore, a regular follow-up is recommended. And in those who are started early, it is recommended that craniofacial evaluation for skeletal dysplasia and malocclusion should be undertaken. This is a study done at Seattle Children's, where they looked at 50 children with average age of 10 years who were compliant with PAP treatment for 2.5 years. And they compared them with 50 children, average age of about 8.5 years, and who were considered non-compliant with PAP therapy. And what they found was that those who were compliant for 2.5 years were found to have mid-face retrusion and dental changes. Thus, the pressure to the mid-face from compliance with PAP use may alter the normal facial growth, suggesting need for surveillance in these children and collaboration between sleep medicine physicians like us and the orthodontists. Sorry. So now moving on to the younger age group. We're going to talk about obstructive sleep apnea in infants. Infants are at risk for OSA for several factors. One, they have upper airway anatomy that favors nasal breathing, and in some patients, switching from nasal breathing to mouth breathing is not as effective. They have compliant upper airway. They have highly compliant rib cage, which favors low functional residual capacity, decreased reserve, and predisposition to more severe hypoxemia. They have immature ventilatory control. Of note, infants have a CO2 apneic threshold that's approximately about 1 millimeter below their eupneic breathing, in contrast to 4 millimeters mercury in adults. Infants have active laryngeal chemoreflex, which results in active glottic closure from stimulation of laryngeal afferents, and infants have REM predominant sleep state distribution. The suggested classification for OSA severity in infants include mild, so it's similar in adults, in children, 1 to 5, moderate is 5 to 10, and severe is greater than 10. And in infants, we add the oxygen saturation of less than 90% for 2 to 5% sleep time. Moderate infants will have less than 90% for 5 to 10% of sleep time, and severe, less than 90% for greater than 10% of sleep time. Easy to remember. 1 to 5 is up to 5 of the sleep time spent with oxygen saturation less than 90%. And when there's an elevated arousal index, this raises the category of the severity. However, more recently, it has been now we know that the infants can actually get better as they grow. There can be improvements, and Dr. Daftari and his team looked at the polysomnography of infants who were born 37 to 42 weeks. So these are termed healthy infants, and they looked at their sleep studies that were performed before 30 days of age. And what they found was that there is a higher AHI in healthy term newborns with a mean of 14.9 events per hour. Most of them were obstructive hypopneas. The oxygen saturation mean is 97.9 with an SpO2 nadir of 84%, an oxygen desaturation index of 17.6, which is also higher compared to what's been described. The time spent of CO2 greater than 45 millimeters mercury was 6.2% of sleep time. The mean CO2 was 35 millimeters mercury, and above 50 millimeters mercury, 50 millimeters mercury was only 6% of this, 0.6 of the total sleep time. Therefore, if we use the AASM definition of 25% sleep time spent above 50, this infant will not meet the criteria of hypoventilation. But we have to put this in perspective in that this infants breathe faster and may not be able to get that peak that we see in older children. So the investigators propose a different way of looking at this sleep study results in infants, and to incorporate the time spent in obstruction as a way of looking at these results that will help guide in your management of these patients. So based on this, their study, a time spent in obstruction was calculated as the total number of obstructive apneas times the mean duration in seconds plus the total number of hypopneas times the mean duration in seconds of obstructive hypopneas over the sleep time in seconds. And what the authors recommend is that less than 2% of total sleep time will be considered as normal in the absence of sleep disruption or gas exchange abnormalities. 2 to 5% of sleep time would be considered as moderate, and greater than 5% of sleep time as severe. When the time in obstruction is less than 2% of sleep time, but is associated with either sleep disruption or with gas exchange abnormalities, then that can be considered as in the milder category. When planning for treatment for infants with obstructive sleep apnea, one can also take into consideration the comorbidities that are present in these children. In a study by Dr. Kupti in Minnesota, they found that infants have a lot of associated comorbidities, and the most common was gastroesophageal reflux disease, and those with genetic syndrome, history of prematurity, and neuromuscular disorders presented with more severe OSA. So how are we going to approach infants with the diagnosis of OSA? It is recommended that the approach should be in a stepwise fashion, starting with the most benign intervention, and it should be multidisciplinary. This may include prone positioning in infants with Ruban sequence, keeping in mind about the risk for SIDS in younger infants, supplemental oxygen, presence of giving anti-reflux medication in light of the increased comorbidity of gastroesophageal reflux in this age group, placement of nasopharyngeal tube, and last would be the surgical intervention. Following a stepwise, individualized, and multidisciplinary approach, the European Respiratory Society recommends the following. In those with adenoidal and tonsillar hypertrophy, one can perform adenoidectomy in infants younger than 3 months, and adenotonsillectomy in those who are 6 months of age. The incorporation of CPAP or non-invasive positive pressure ventilation for those with moderate to severe OSA, high flow nasal cannula, or surgery depending on the main cause of the OSA. For example, those with laryngomalacia may benefit with supraglottoplasty. Those with micro or retrognathia, such as those with Ruban sequence, may have an option of mandibular destruction. Also, lip-tongue adhesion and tracheostomy may still be needed in some infants. So those with complex conditions, like those with achondroplasia, may have options of adenotonsillectomy, placement of nasopharyngeal airway, and CPAP if CPAP or passive airway pressure if the condition persists. Those with Chiari malformation may improve with adenotonsillectomy, non-invasive positive pressure ventilation, or surgical decompression of the cervicomedullary junction. Patients with Down syndrome, who we will discuss later, and the Prader-Willi Syndrome will also benefit with adenotonsillectomy. Patients with Down syndrome may benefit with supraglottoplasty or CPAP, and those with Prader-Willi may benefit with adenotonsillectomy and the addition of oxygen in those with central sleep apnea. So, with institution of therapy, it's important that infants are followed very closely. Those who undergo adenal tonsillectomy, it is expected that there can be a recurrence, and these infants, particularly if they have other comorbidities, can have persistence or recurrence of symptoms. Therefore, they should have a repeat polysomnography. The European Respiratory Society recommends 4 to 6 months post-procedure. In those who are treated with CPAP, they require clinical evaluation and nocturnal monitoring every 2 to 4 months during their first year, and then every 6 months thereafter. Because they're growing, we need to make sure that we confirm their need, we need to adjust their pressures, and maybe an upgrade of their mask size. Patients with neuromuscular disorders who are treated with non-invasive positive pressure ventilation will require nocturnal monitoring upon initiation and then annually. Those with supraglotoplasty will require nocturnal monitoring 1 to 6 months post-operatively to assess effectiveness of the therapy. Those with Robin sequence may require monitoring every 2 months if nasopharyngeal airway is the treatment of choice and after removal of the nasopharyngeal airway. And then those with mandibular destruction osteogenesis will need serial nocturnal sleep studies to assess the efficacy of the treatment. So for the RSO review, what is laryngomalacia? Laryngomalacia refers to inspiratory collapse of the epiglottis, as seen here, and the arytenoid cartilages, resulting in airway obstruction. It is the most common cause of inspiratory stridor in infants, and this inspiratory stridor worsens usually with feeding, crying, supine positioning, or agitation. And they can be associated with feeding difficulties, including coughing, choking with feeds, and slow feeding. Up to 50% of infants with laryngomalacia have comorbid airway lesions like tracheomalacia and subglottic stenosis, and many are associated and are exacerbated with gastroesophageal reflux. And the natural course, though, of laryngomalacia is that it typically spontaneously improves over the first 12 to 18 months of life. However, OSA is very common in infants with laryngomalacia in up to 79% in one series, but most of these are associated with mild OSA, and 20% may have severe OSA with hypoxemia, failure to thrive, and these patients will require surgical intervention. Polysomnography is indicated when these infants with stridor and laryngomalacia show respiratory distress, either awake or during sleep. They have poor feeding and have failure to thrive. And in laryngoscopy and bronchoscopy is needed in those with moderate to severe OSA or respiratory distress due to the concomitant comorbid airway lesions in these patients. So the treatment for those who have failure to thrive or with moderate to severe OSA can include supraglottoplasty, and this has been found to be effective, but is associated with residual disease commonly. And the indications are noted here for the surgical intervention. So now we're going to move to another disorder that's we see in pediatrics. It's Down syndrome. There's a high prevalence of OSA in patients with Down syndrome, up to 50 to 76% of patients with Down syndrome. Half of these children will have moderate to severe OSA, and there is a high prevalence of associated pulmonary hypertension. It is OSA in Down syndrome can be underrecognized and untreated because parental histories do not necessarily correlate with PSG findings. Therefore, the American Academy of Pediatrics gave us this guidance that all patients with Down syndrome should have a sleep study by 4 years of age. So what are the risk factors for OSA in patients with Down syndrome? They have mid-face hypoplasia, They can have adenoidal and tonsillar hypertrophy, large tongue, malacia like Laryngomalacia due to their hypotonia, Laryngomalacia. In one series, it occurs in about 50% of children with Down syndrome. They have mandibular hypoplasia, they can have hypothyroidism, and they may be obese. So a treatment of children with Down syndrome, the first line remains adenotonsillectomy, and those with Down syndrome need to be admitted for post-operative monitoring due to their high risk of respiratory complications. However, there's also after adenotonsillectomy, there's a group of patients, up to 50% of patients who will have persistent or recurrent OSA. And this can be due to other areas of airway obstruction, like the presence of macroglossia, glossoptosis, regrowth of adenoids and tonsils, presence of lingual tonsils, and the hypopharyngeal collapse. So how do we manage patients with persistent or residual OSA after adenotonsillectomy? They can be placed on CPAP or BiPAP. Some patients may require additional airway surgery, such as supraglottoplasty for those with laryngomalacia, lingual tonsillectomy for those with lingual tonsil development, tongue base reduction, or mandibular distraction. Some patients have undergone rapid maxillary expansion, and those who are intolerant with CPAP may benefit with high-flow nasal cannula and hypoglossal nerve stimulation for refractory severe OSA have been used as a therapy in some adolescents with OSA and Down syndrome. So this is the study where hypoglossal nerve stimulation in adolescents with Down syndrome and OSA, they found clinically significant improvement with institution of this mode of therapy. So what other managements can we institute? Leukotriene receptor antagonist or intranasal steroids have not shown significant improvement in those with mild OSA. Weight management, which is always aspirational but sometimes difficult to achieve. And it's important to have screening of thyroid function for these children in infants every 6 months until 1 year of age, then annually. And in those presenting with OSA, must have verify that they have a normal thyroid function test. The next condition that I would like to go over briefly would be the Prader-Willi Syndrome. There's a significantly high prevalence of OSA of up to 80% in this group of patients. They have risk factors include altered ventilatory control. They have blunted hypoxic and hypercapnic ventilatory responses. They have higher arousal threshold to hypercapnia. They're obese. They have hypotonia. They have facial dysmorphism with micrognathia, hypothyroidism as well. And in those who are started on growth hormone, the growth hormone can contribute to the growth of lymphoid tissues. There are age-related differences in the sleep apnea phenotype in patients with Prader-Willi syndrome. Those who are younger, less than 2 years age, have more predominant central sleep apnea. And those who are older than 2 have more predominant obstructive sleep apnea. And the central sleep apnea may be related to delays in maturation of the ventilatory control centers or to an abnormal apneic threshold. Therefore, how do we approach patients with Prader-Willi syndrome? We have to screen for OSA, have a high index of suspicion. And the treatment, again, would be a trial of adenotonsillectomy, remains the first line, knowing that there's a risk of post-op complications, particularly velopharyngeal insufficiency, which is the most common, and they have residual OSA. When they have residual or persistent OSA, they can be treated with CPAP or BiPAP, behavioral intervention so they don't eat too much, and weight management. So in a study of outcomes of a tonsillectomy in patients with Prader-Willi syndrome, it has been found that it's effective for mild to moderate OSA, not curative for those with severe OSA, but in those who have undergone adenotonsillectomy, it has also been found that they may have increase in central apneas in some children post-operatively, that these children should have repeat polysomnograms. Those who are being contemplated for treatment with growth hormone, it is recommended that they have a baseline polysomnography prior to growth hormone therapy. If OSA is present and the tonsils and adenoids are enlarged, they may undergo adenotonsillectomy, and then repeat the PSGs periodically, particularly if there's no onset of snoring after initiation of growth hormone therapy and or within a few months of starting the therapy. If present, they can be treated with positive airway pressure. In the younger age group, and because of central sleep apneas, they may benefit with oxygen supplementation, as oxygen desaturation is common. Therefore, supplemental oxygen may be added as part of their therapy. And last would be patients with epilepsy. They are at risk for OSA, and the treatment in those with refractory epilepsy is vagal nerve stimulator. It is important to know that vagal nerve stimulation increases AHI in most patients. Patients can have central apneas, obstructive apneas, and hypopneas, and the sleep-related breathing disorders due to the adduction of the vocal cords. And therefore, because of the increased risk of OSA, it's important that these patients have assessment for undiagnosed and untreated OSA before placement of the vagus nerve stimulator. And when there's snoring or symptoms of OSA, they need to be reevaluated as well after implantation. So how do we manage patients with OSA who have vagal nerve stimulator? We can ask our neurology colleagues to change the operational parameters and as well as placing these patients on CPAP. So lastly, my take-home messages are pediatric OSA is common. Polysomnography remains the standard in the diagnosis of OSA in children. Adenotonsillectomy is the first line of treatment in many patients. Pre-adenotonsillectomy, PSG aids in the therapeutic planning. Some children have higher risk of complications following adenotonsillectomy and require monitoring. Post-adenotonsillectomy, PSG is indicated in some patients, and watchful waiting is reasonable in non-obese children with mild OSA and symptoms. And a stepwise and multidisciplinary approach is required in the management of OSA in infants. Those with Down syndrome should have a sleep study by 4 years of age. Patients with Prader-Willi syndrome may develop velopharyngeal insufficiency following adenotonsillectomy. Some patients with Prader-Willi syndrome may have increase in central apneas following adenotonsillectomy. And patients with epilepsy who are treated or being contemplated for placement of vagal nerve stimulator should be screened for OSA with PSG. Thank you very much. And I think I am ready for questions if Sally tells me when to answer.
Yes, actually, before we do the questions, I'm going to post just a few poll questions. If you would answer these. While you're answering them, you can also add questions to the chat or take yourself off mute and ask them. Okay, we will end this poll. And let's see, we will do the next one. That's the second question. Please answer. Okay. I will end that poll. Just 2 more questions to go.
Okay, I'm not looking.
Okay, and the final question. And then we can go to questions. Okay, thank you so much. Dr. Perez, would you like me to read the questions
Yes,
to you?
please.
Okay. Let's see. What is your typical clinical practice for children with mild OSA? Do you usually refer to ENT versus trying medications and or watchful waiting?
So it really depends on the clinical presentation. If they have a mild OSA, so it will be less than 5 per hour of sleep without significant oxygen desaturations and without obesity, and they're normal, and the tonsil is like +2 or +3, then I present the 3 options to the family. And this is what we call, I would say, almost like a family-centered rounds. So I would say, the number 1 treatment would be referral to for adenotonsillectomy. I still do think, because there's still some previous studies where there are neurocognitive, although there's no improvement in executive function, there is improvement in the other parameters. So I would present that. I will refer to ENT for adenotonsillectomy. And then 2 would be, while waiting, I may present with medical treatment, leukotriene antagonist and or nasal steroids. And if the family don't want anything, then I would present, maybe we can do medication and then we can repeat. If they absolutely do not want to do any treatment, then I would definitely repeat the sleep study in 6 months to a year.
Okay.
Does that answer your question?
Yes, she said yes. Okay. She said yes. The next question is, AASM states AHI greater than 1 is diagnostic. Why do some labs use an AHI of 2?
Because, well, I would say our lab, actually, in our center, we use AHI of 1.5. So, because I think many studies may have used AHI of 2, and then it's when you are in that category where you may actually consider treatment or observation. So I think it's just important to know which part of what your lab is using as abnormal, but an AHI of 1 is abnormal, but that will really then determine your how are you going to approach an AHI of 1. So for us, we use an HI of 1.5, and depending on symptoms, and again on the symptom score or the severity of the symptoms, that's when we decide. Each practitioner will decide how to go about it. So I can't say but we use in our lab, we use 1.5.
Okay, thank you. Another question, how will I know the duration of the obstructive events, 2 breaths, if I have no breath, based on respiratory effort?
You can, yes, well, the manual. We have 2 Bibles, right? One is the ICSD, and the manual for scoring actually has a nice description of how to find the 2 breaths.
Okay. And why is the age related to persistent OSA after surgery?
Age, can you repeat the question?
Why is the age related to persistent OSA after surgery?
In that outcomes, in that the 2010 study that's published in the in the journal, they just found that, and they did not really. There was really no speculation, I believe, about that. So it is possible. There are many things I could think of with age. There's the development of obesity, but I don't think that that's what was in the study.
Okay, and I
have to look into it. Yeah.
I believe you answered this question. Diagnostic AHA is greater than 1 or greater than 1.5.
Mm-hmm. You just need to know which. You just need to know what your lab is using. Like I said, our center, we use 1 greater than 1.5. 1.5 or greater.
The next question, what is your take on heavy snorers? I always end up treating them and look at the snore arousal index, especially if symptoms seem out of proportion to their disease severity in mild OSA.
So my take would be, I would look at the mild OSA, but it looks like there's a high symptom score, so I would treat, if that is my take, depending also on the what is the outcome. Is there daytime or nighttime manifestations? So I would, if my PSG says mild OSA, but there is a lot of symptoms associated with it, then I would think of treating.
Okay. And we have another question. Is there a reference for normal sleep stage distribution during a typical night in newborns and infants and toddlers?
Yes, and actually I would refer you to the Daftari. They have a new reference on the percentages. Okay. Oh, sorry, Sally. Do they get a copy of my slides, or how does that go?
Well, actually,
I said yes, but then yeah.
We post the video, the lecture on the Choose Sleep website in approximately 2 weeks. If you want me to send the PowerPoint, I can. That's up to you.
Well, I am, if someone requests, I am fine, because the references are there.
Okay. And they can contact me, spodolsky@aasm.org, and I will be happy to send the PowerPoint presentation to you.
Or you can also contact me at iAperez@chla.usc.edu. I don't know how to put that in the chat.
Okay. if anyone has any more questions, please just undo your mute or put them in the chat, and because we're almost at 11 o'clock.
Thank you, everybody, for your time.
Thank you, Dr. Perez, for the wonderful talk.
Thank you.
Thank you.